USMLE Forum of Pakistan presents USMLE Step 1 Cardiovascular System QBANK, and we will be continuing on with the series. So, 78-year-old man presents with a month history of progressive dyspnea, generalized weakness, and palpitations, tingles, numbness, both legs. His daughter notes he has neglected self-care since his wife's death a year ago. Vital signs show blood pressure 105 to 50. Pulse examination shows displaced apical impulse, a third heart sound, and high volume collapsing carotid pulse. Bilateral basal crackles, 2 plus pedal edema, and mild hepatomegaly. Neurological exam demonstrates decreased light touch and vibration sensation with reduced knee and ankle reflexes bilaterally. And the blood is showing normal counts. So they're basically asking what is the most likely deficiency in the patient. This is basically asking the deficiency of the nutrient, right? Now, this is a kind of a biochemistry question that can present in the real USMLE. Also, this question you might encounter countless times in U World also. So this is how biochemistry is asked. Many students ask me that how does biochemistry present in the paper? So the biochemistry, one portion, one aspect of it can present as the question that you're saying. This is the nutrients part of the biochemistry can present like this. Going through the options, deficiency of ascorbic acid is the wrong answer because in the question you have to identify what the problem is. All right, there are two problems in the patient. Number one is the heart problem. Right, there is a heart problem. Okay, and then there is a neurological problem. The neurological exam is showing decreased light sense, vibration in the feet, and also then reflexes are reduced. There is also numbness and tingling, which shows neuropathy basically. He is also having heart problems, as you can see, third heart sound, high volume collapsing carotid pulses, apical impulse. So third heart sound I have explained in the previous videos also means dilated cardiomyopathy, which means more blood is coming into the heart. The high volume collapsing carotid pulses is pathognomonic for high blood flow in the heart. Again, the cardiac output is high. So there is high blood flow. There's a third heart sound and there is high volume collapsing carotid pulses. If the cardiac output is high, the carotid pulses will also be higher because more blood is getting sent into the carotid arteries. That is why you have to remember this phrase, that this is pathognomonic for increased cardiac output. So basically, in the heart aspect of the things, he is having increased cardiac output. And the neurological defect is that he's having a neuropathy. One disease that you have to keep in mind, which has both heart and neurological problems, and it is basically a nutritional deficiency, is the deficiency of thiamine, which is vitamin B1. Right answer is thiamine. That's the correct answer. It could present as wet beriberi or dry beriberi. So the deficiency can result in wet beriberi and dry beriberi. The wet beriberi will result in heart and neurological problems. Heart plus neurological problems. And the dry beriberi will only present with heart problems. That's it. That's the only difference you need to remember. That the wet one will have both, the dry one will only have the heart. There is a pathology associated with it, which is, I'm just going to tell you the important high yield aspect of the pathology, which is when thiamine is deficient in the body, there is accumulation of lactate. When lactate accumulates, vasodilation occurs. So when vasodilation occurs, what happens is that the heart starts to pump more blood. Although you can see the pulse is 104 per minute. excuse me. The normal one should be 80 till 100. 80 till 100. Okay. But in this patient, the pulse is above 100. The pulse is increased. The pulse is high. The pulse is high, which means the heart is contracting and it's pumping more blood. What is happening is the cardiac output is increasing, but the blood is not perfusing the tissues efficiently because of the thiamine deficiency and the vasodilation that is occurring. That is why high output cardiac failure occurs in thiamine deficiency. Thiamine deficiency can be found in alcoholics or people that are malnourished. That is why this clue is given that he has neglected self-care, which means he might not have adequate nourishment. So you have to keep these things in mind. So this is the pathophysiology of it. Discussing other options, ascorbic acid is basically vitamin C. Vitamin C deficiency can result in scurvy. And scurvy does not present with any cardiac or neurological problems. Scurvy can present with gingivitis, petechia, corkscrew hairs, poor wound healing, but no cardiac or neurological problems. Cobalamin is again the wrong answer because cobalamin is vitamin B12. Vitamin B12 classically causes megaloblastic anemia. It can cause subacute combined degeneration, which can present as decreased vibration sense. But the question is pushing you towards the direction of time. And again, there is no clue given. There's no discussion of pernicious anemia. There's no discussion of any nutritional deficiency. There's no discussion of any dietary uh, negligence. But they have, however, mentioned that he self-neglected, but they have not specifically mentioned vitamin B12 can be obtained from an animal diet. You have to remember that. So if there's a person that is vegetarian strictly, you have to treat him by giving him vitamin B12. Cool. Pyridoxine deficiency can occur when someone is undergoing tuberculosis treatment and he is being administered isoniazid. That is why you give vitamin B6 prophylaxis, pyridoxine prophylaxis with someone who is going isoniazid treatment. Isoniazid can cause peripheral neuropathy due to B6 deficiency, pyridoxine deficiency. Pyridoxine is B6. I should mention it, pyridoxine is B6. Cobalamin is B12. So niacin is B3. The niacin deficiency can result in pellagra, which is remembered by 3 Ds, dementia, diarrhea, dermatitis, and death. Dermatitis can present as it's basically called as the cable necklace, and dermatitis occurs in the areas that are exposed to the sun. So you have to remember that. This is the wrong answer. And this is B3. I know this is getting cluttered, but you have to keep in mind these vitamins are very important. Retinol is vitamin A. Deficiency can result in night blindness, xerophthalmia. Xerophthalmia is high yield for xerophthalmia basically presents as dryness in the conjunctiva, bi-dot spots. Riboflavin is B2. And B2 deficiency can cause glossitis, stomatitis, seborrheic dermatitis. Glossitis, stomatitis, and seborrheic dermatitis. So you have to remember that triad. There is no cardiac or neuropathic impairment in thiamine deficiency. Okay, moving on. So this goes without saying, but you guys need to pause the video and to try the question yourself and see if you can do it, and then continue on watching the video. All right, long distance runner. He's 24 years of age, and he presents for exercise evaluation after a teammate died suddenly in their sleep. And he has it's a maternal history, which is not relevant until you have any mitochondrial disorder or X-linked recessive disorder. So maternal history is not really necessary in most of the questions, unless it is a genetic question. Then it is important, or any disease that is X-linked recessive or mitochondrial. Basically, you can see that he has a resting bradycardia. That is a clue that you have to identify. Let me fix this. This is a clue that you have to identify is resting bradycardia. Okay. And he is an athlete. So I've done this kind of a question before in the video also. So I think most of you now would have guessed. But these are very important. These adaptations you have to remember. This is a very important question. You have to remember. So the ejection fraction stays the same. The mass increases. The wall thickness increases, but this is uniformly. This is asymmetric and hypertrophic cardiac. The cavity size increases. The ventricular and atrium is mildly enlarged. Not very much, but only mildly. These all adaptations you have to do. Right ventricular cavity is slightly enlarged, and there is no valvular damage. So basically asking what is the explanation of these echo findings. And this is, you can see you can understand that the answer for this is cardiac adaptation, because cardiac adaptation in the athlete is athlete's heart. So you have to remember AH signifies athlete's heart. This is important for USMLE. This question you will encounter in the NBMEs, you will encounter in the U World, you will encounter in the real paper. This is quite important. This is very important. You have to remember all these adaptations. The difference I have explained, this is the difference between hypertrophic obstructive cardiomyopathy. What's the difference? This will not decrease in normal physiologic adaptation. Discussing other answer choices, anabolic steroid use will present as increased hemoglobin. It can present as gynecomastia, testicular atrophy because of the increased testosterone. It can present as mood changes because testosterone induces aggressiveness. Hypertrophic cardiomyopathy is already a wrong answer because I've already explained why it wouldn't be. Premature coronary artery disease will not happen in an otherwise healthy patient and will not have these changes. Left ventricle size will not increase because it won't have any load on the heart. Coronary artery disease will induce ischemia, and ischemia will in turn present as a stress, not as a load. And subclinical viral myocarditis will not be because there is no history of any infection that the patient has gone through, and this has decreased ejection fraction normally. Yep. So the ejection fraction is the same. So this will not be the answer. Moving on to the next question. The clues I will highlight after you read the question. Okay. So this is a 14-year-old girl and presents as just in general examination. She has no sexual activity and substance abuse. The height is at the 5th percentile. This is an important clue. And the weight is at 25th. These are the vital signs. There is no problem with the vital signs. Short, thick neck, broad chest, and bilaterally shortened 4th metacarpus and cardiac murmur. This is the important part. This is the basic presentation of Turner syndrome. Turner syndrome, right? These are important high yield findings that you have to remember. There are multitudes of findings in Turner syndrome, but these are important. The short, thick neck, step neck, broad chest, spaced nipples, bilaterally shortened 4th metacarpals, cardiac murmur. These things you have to keep in mind. Coarctation of aorta is another association that is high yield. Also, Turner syndrome patients are short-heighted. Which of the following would be seen on echo? Right? What is the valvular problem that Turner syndrome patients have? So, right out of the gate, that this is a factor that you have to know that this is the right answer. Bicuspid aortic valve. This is what Turner syndrome patients have. Atrioseptal defect is not the right answer because atrioseptal defect obviously is not associated with Turner syndrome. So this is we are handing you the diagnosis of Turner syndrome, and air to septal defect has no association with them, and they've given you the fixed split S2, which is mnemonic for it. Mitral stenosis, if this was a mitral stenosis case, they would have given you the heart sound. They would have also given you a history of rheumatic fever, which they have not given. Mitral stenosis is basically a diastolic rumble. Mitral prolapse present as mid-systolic click. Of course, they're not giving the sound. They've also not given you any history of the Marfan syndrome or any other disorder, connective tissue disorder, classically, which is Marfan syndrome. Patent ductus arteriosus, again, it would present in a neonate or someone who is an infant at most as a continuous machine-like murmur, which is not given, and no symptoms as well. And VSD is obviously not there. Although very high yield, it is associated with Down syndrome. It can present as a holosystolic murmur. Okay, so this is it for this question. Let's continuing on with this question. Hopefully you read it. Okay, so saying that the woman comes to the emergency department, 30 minutes left-sided chest pain, nausea, vomiting. She has family history of maternal MI and left side tenderness to palpation. ECG is normal. She's scheduled for an exercise stress test. During the stress test, which of the following parameters is most likely similar between the systemic and the pulmonary circulation? So I've also explained this in one of the previous videos, but I think it should be done in a better way here. So something you have to understand that the arterial resistance is the wrong one. So because arterial resistance is lower, it is lower in the pulmonary circuit, higher in the system. I think most of the people will understand this, that systemic arteries are large. And that is why the resistance will increase. There are more arteries, there is more division. The more the division of arteries increases, the resistance increases. If this is an artery and divides into this, right, this has low resistance. Or if this is an artery, divides into many small branches, this has high resistance. This is high resistance. This is where the resistance, it is encountering resistance over here. The blood has to stop and divide. So that is why pulmonary arteries have lower branches. Systemic arteries have more branches. It has capillaries. There are no capillaries in the pulmonary vasculature. So arterial resistance will decrease. Diastolic arterial pressure will also is the wrong answer because it is lower. Diastolic arterial pressure is lower because pulmonary artery, which is involved in the pulmonary vasculature, comes from the right ventricle, and right ventricle has lower diastolic arterial pressure. This is the wrong answer. Pulmonary artery is predominant in the pulmonary circulation. So you have to look at that. Everything you choose, you have to look at that. All the options you have to compare with the pulmonary artery situation. So the right ventricle has lower diastolic pressure, and of course that same would happen in the pulmonary artery. So that would not be similar. Driving pressure for blood is basically dependent on the mean arterial pressure, which are both are the wrong answers. Because what will happen is that if there is more mean arterial pressure, the difference is more between the systolic and diastolic. There will be a higher difference, and of course the pressure gradient will increase, and the blood will flow much better somewhere where the pressure gradient is more. So the pressure gradient is decreased, the blood flow will decrease. So you have to remember that the driving pressure depends on the pressure gradient. Why is the pressure gradient more in the systemic? Because as I said, there is more resistance. Also, the diastolic blood pressure is higher in the systemic. Systolic blood pressure is higher in the systemic vasculature. That is why the difference is more. Mean arterial pressure is more, and that is why the driving pressure is more in systemic and less in pulmonary. Arterial oxygen content is highest in systemic because the blood has freshly come from the lungs. But in pulmonary artery, there is deoxygenated blood going from the right ventricle towards the lungs. But you have to keep this circuit in mind, that this is the left, so the right ventricle, and then this is going to the lungs, and then this is going to the left ventricle, then to the body, and then to the right ventricle. So pulmonary artery is here. How can oxygen content be same in both of them? They cannot, right? So this is the wrong answer. The correct answer is blood flow per minute. Why is the blood flow per minute the correct answer? Blood flow per minute basically means what is written, exactly how it is written. Blood flow means that the amount of blood that is flowing per minute, which means the cardiac output. The cardiac output is the same in the aorta, in the pulmonary vasculature, in the pulmonary artery. The blood is pumping the same amount in both the compartments. There is no difference. The only difference is of the resistance, of the pressure, but the volume of the blood stays the same. You have to remember the volume stays the same. Right, moving forward. So read this question now and we will discuss it. After reading this, we will discuss it. Okay. So question is asking that the patient is presented at the emergency department with severe substandard chest pain, sweating and mild dyspnea. Preventing sleep basically means that the pain is unbearable. Medical history is significant for hypertension, type 2, diabetes mellitus, and hyperlipidemia. Nitroglycerin is provided, but it has no relief, and the ECG is showing ST elevation. This is a classic case of STEMI. Now, STEMI presents with ECG elevation, ST elevations in the ECG, and unbearable pain, which is not episodic. So this is a case of STEMI. So right off the bat, we could select the option of ruptured atherosclerotic plaque with 3 thrombus. C is the correct answer. This is STEMI. You have to remember this presentation. This is important, right? System STE. Okay. 50% obstruction is stable angina, no thrombus. They are specifying that there is no thrombus. So this will not show any ECG changes. This is stable angina, episodic pain. 80%, this is the wrong answer. I don't know why I've ticked it, but this is the wrong answer. This is also the wrong answer because this is showing 80% obstruction of the coronary artery. This is again no thrombus. This is unstable angina. Now, this pain would not occur in rest, unlike stable angina. This would occur anytime, but this will show ST segment depressions. This would show ST depressions, not elevations, depressions. This is a part of acute coronary syndrome, along with NSTEMI and unstable angina, NSTEMI, and STEMI. Option D is also the wrong answer because it is mentioning vasospasm, which means that this is pointing towards Prinzmetal angina. Prinzmetal angina, which is episodic, unrelated to rest, and it only shows ECG changes, ST elevations when the episode is occurring. Option E is also incorrect because atherosclerotic plaque will, it is mentioning that it has a partially obstructive thrombus. This is NSTEMI. This is the NSTEMI. Because the thrombus is present, but it is partially obstructing. So this is also have ST segment depression. Now the difference between unstable angina and NSTEMI is that in NSTEMI, troponin levels will also be high. Troponin will be high. And in unstable angina, all the cardiac biomarkers will be normal. Cardiac biomarkers will be normal. Okay. So that was it. This description is high yield. You have to remember that. for all of these different conditions. And you have to remember the difference between the presentation. So, cardiac biomarkers and ECG changes. Okay.